Welcome to PharmaDocs with your host, myself, Dr. Jay Resnick, and Dr. John Robertson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Well, good evening, John.
Hello,
and
Jay.
Happy
New
2024,
Year.
yeah.
Yes, we are now
we made it
in
another year.
2024. Man,
Yeah.
how many years have we been doing this, educating our fellow dentists? 3 years?
Well, just PharmaDocs alone, but yeah, before that, probably 20 years. But yeah, this is our third year doing PharmaDocs now.
Yeah.
We started in 2022.
Where else can you get it for free? Huh?
I know, really.
I mean, we're going to bring you some stuff as well, too, and we're going to keep bringing the stuff because we're practicing clinicians just like our audience. We're out there every day in the trenches. We're in the grind. We know what it's like.
Yeah. We get the crazy patients too.
Yeah. I mean, sometimes everything goes great. Sometimes they don't. Yeah. And no matter what, you got to pick yourself up and keep moving forward. But again, we're in the greatest profession ever. I love dentistry. I love working with my colleagues. And Jay, I just enjoy so much doing PharmaDocs with you because, I mean, not only does it help us, but it helps our colleagues as well, too. Mm-hmm. But look how many drugs come out all the time.
I know. Just 9 this month, right?
9 this month. Last month, that is. Yeah. That's right.
Yeah, we don't know yet how many are for January.
But, okay.
It's not over.
But, okay, with the whole year of 2023, Jay, okay, you know, if we have 9 per month, we're looking at 108 drugs right there. And I just love your analogy that you said early on when we started PharmaDocs. If there's 100 drugs coming out every year and you've been out in practice for 20 years, that's 2,000 new drugs that you're going to need to know something. Maybe not have heard of them, but it could affect the way your treatment is being delivered to your patient.
Yep, because patients taking those drugs will show up in your office.
All right, so let's kick the new year off, Jay, we always do.
Go.
Okay, hey, look at that.
Happy New Year.
Happy New Year. Yes,
all right.
I hope all of our colleagues have a prosperous new year. I really do.
January 12th.
Yes.
Already. Wow, it seems like it was just Christmas.
I know.
All right. So before we get going, we want to thank some of our sponsors.
They stayed with us. We like them. Thank you.
John, why don't you take this part?
Well, iCore RX, Jay, I mean, they are the go-to for e-prescribing for dentists. I mean, Jay, I want to say they're close to being in almost all the state dental associations now. And
pretty much.
Yeah, how nice it is to make, your life easier e-prescribing. They've got it figured out. iCore RX.
And the fact that you can do it from your phone also.
Correct.
Is great. And then we have
Fortune Law Firm. You earn the money, we help you keep it. And, Jay, what a great firm this is. It's dedicated to healthcare professionals being dentists. Not only is it for asset protection, estate protection, but also license protection as well, too. Yeah. So they work alongside with your malpractice carrier.
Mm-hmm. And your CPA.
That's correct. Yes.
Yeah. So that you can
get a good tax strategy.
Exactly. And then, of course, our newest is good old Vesper Institute in Cincinnati, Ohio, where John and I are going to be. Actually, we started already. We started last year teaching IV sedation training to general dentists. And we absolutely love it. We love what we have developed here. We've got the general dentist, or even some other specialists like periodontists, Jay, or endodontists. If they're any of them are interested as well too. We've got the program for you because we love how we've developed it in various different phases: the online, the in-person didactic, and then clinicals. Yeah.
But the great thing about it, once you graduate from Vesper Institute, you now become part of Vesper Nation, Jay, and we're always going to be available for any of our graduates as well too.
And you get a really cool T-shirt.
Absolutely.
Yeah. And the great thing about the hands-on portion is rather than doing it in a hospital and putting in a bunch of IVs and that counts as your sedation training, you're actually working side by side with an IV sedation trained general dentist who will be your one-on-one mentor for your 20 plus IV sedation cases that you need to do in order to get your permit to do IV sedation in your state.
And our next class, Jay, is April this year.
That's right. In Cincinnati at VesperInstitute.com. And then actually we have another new sponsor, Balanced Pharma. And this is really something that we are excited about. It's a new company. They have a new product, which is really an old product, local anesthetic.
But a new delivery method.
Exactly, because local anesthesia, is acidic. And patients hate getting local anesthetic injections because it burns so much.
Correct.
So in medicine, and when I suture someone's face, I will buffer my local anesthetic, my lidocaine, with sodium bicarb.
Yes.
And it reduces or increases the pH so it's not so acidic, and it gets rid of the burning. It also kicks in faster. And so patients don't mind the injection. And it took a genius with a simple idea to say, hey, I know how to do that for a single-use dental carpule.
And do it better.
So
and he did it.
Mm-hmm. So it's going to be a single-use dental, just like a dental carpule, that will have the buffering agent in it that's activated when you put it in your syringe, which is really cool. And you'll hear more about this as time goes on.
But go to the website, balancepharma.com, and get educated about this new product that's coming to dentistry. It's going to be a game changer, Jay, because what are the 3 worst words we all want to hear? You hurt me. During an injection or something like that. Now you're taking care of that burn. You're getting rid of it. So what's in the news, Jay? What have we got going on so far?
We got a few things in the news. So there's this bacterial infection, Acinetobacter baumannii, that goes by the nickname crab. I'm not sure quite why, but it triggers serious infections in the lungs, urinary tract, and in the blood. And it's been resistant to pretty much every antibiotic they've thrown at it. But a group at Harvard University, in conjunction with Hoffman LaRoche, discovered a new antibiotic, zosurapalin.
That's close enough.
Which actually can kill this bacteria. And the way it works is, it works especially well on gram-negative. This bacteria is gram-negative. And so it's got a double cell wall. And what it does is this molecule gets inserted between the 2 cell walls. And it basically prevents lipopolysaccharides to get to the outer membrane of the bacteria. And it basically lyses them. By basically hogging all the space between the 2 membranes. And so that's really kind of interesting. It's a novel mechanism.
Okay.
And it's now being tested in phase 1 trials to assess its safety in humans. And the only drawback is that it's only the modified molecule will only work against a specific bacteria that's designed to kill. But this opens the door for more and more new antibiotics for specific resistant organisms.
Yeah. Because, the biggest concern we're always worried about is MRSA. So the newer antibiotics or new mechanisms or first-in-class drugs or novel drugs, as you said, are welcomed. So what are the new risks we're seeing with the new weight loss drugs? Because, Jay, I saw something the other day. We've been talking about it since we started. I mean, we were around 35% in the obesity. Then we got to 40. I saw something yesterday said 42% now. Wow. 42%.
I would believe it.
Yeah, and of course, what I'm hearing on the new risk and all that stuff is, once you get off of it, bloating, constipation, or diarrhea. Or is this what you're seeing also?
Well, also when you're taking it, those are some side effects. In addition to the one I think we talked about before, with the mechanism of delaying gastric emptying, we're finding patients who were, well, fortunately we aren't, but they are finding patients who were NPO for surgery for at least 12 hours that still have food in their stomach.
Yes.
Which is extremely dangerous. In fact, I read an article about one patient, I think, had been NPO for days and still had food in their stomach. So now the recommendation is any patient who are on any of these GLP-1 receptor agonists like Ozempic, Wegovy, Mounjaro, Zepbound, to stop using it at least a week before going under anesthesia.
Yes.
Yeah, but these new side effects are hair loss, aspiration of food, and suicidal ideation in people who've used the medications. Although I have seen in the last week a number of articles saying that the suicidal ideation rate is no higher in patients on these drugs. So
yeah, and the aspiration,
it's just something to consider.
Well, I think the aspiration, we're going to address that because, like you said, we're now saying stop it a week before.
Yeah.
Because unfortunately it did take some cases to say, hey, wait a second, what's going on here as well too.
Yeah. But there have been 422 reported cases of hair loss.
Oh gosh.
With this drug. Number of cases of food left in the stomach for surgery.
Okay.
All right. So the next one is, in early research, heart drugs show promise in fighting muscular dystrophy. Specific type, myotonic dystrophy type 1, which is caused by abnormal RNA that affects the calcium channel receptors, and basically interferes with normal nerve impulses to get muscle movement. And the muscles actually become static. They go into spasm, and patients will have muscle weakness, prolonged muscle tension, which will over time affect their eyes, their breathing, heart and brain, swallowing, and ultimately ends up in fatality for these patients because of this. So this is a new drug. Actually, it's not a new drug. It's an old drug that has been found to actually have some therapeutic value, at least in mice. And that's calcium channel blockers like verapamil.
Yeah, verapamil, isoptin.
Yeah.
Yes.
And basically what it says it does is genetic stutter results in thousands of repetitions of code on a segment of chromosome 19. And that defect causes an accumulation of abnormal RNA. But what the calcium channel blocker does, it might be able to eliminate this noise caused by the abnormal RNA, allow normal neurotransmission to occur.
Interesting.
Yeah.
And then we got omega-3s that I'm sure most of our audience, I hope you're taking some type of fish oil or fish capsule, something like that, could slow a deadly lung disease.
Mm-hmm. Especially in smokers. Pulmonary fibrosis is the one that they found that it actually can help. When it comes to the omega-3s, there are studies that are show benefit. There's some that show no benefit, but they definitely, in this report that came out of Virginia School of Medicine and UVA Health in Charlottesville, they had 300 patients with interstitial lung disease, and in the patients that had higher levels of omega-3 fatty acids were predictive of better clinical outcomes. And they were also better able to survive without needing a lung transplant.
And so, Jay, I couldn't help but laugh when you said some are in favor, some against. Yeah, it's just like drinking coffee. Mm-hmm. Every month we're going to get a study saying it's good for you, and then next month it's bad for you. Right. But I'm going to drink my coffee.
Yeah.
Coffee's good for you.
Exactly. I like it.
Yeah, I like it too.
Gets me going in the morning.
But hey, look, to end it with, finally,
the mystery's been solved.
After 100 years, I couldn't believe as I was reading about this that we didn't know.
Yeah.
I was like, well, wait a second. Yeah, I had to do a double take and say, no, that's not true. There's no way.
And this came from the University of Maryland's Department of Cell Biology and Molecular Genetics. They finally figured it out.
It's all due to bilirubin.
Yeah, breakdown of bilirubin, a byproduct. Byproduct of the breakdown by the enzyme bilirubin reductase converts it into urobilinogen.
Yes.
And then urobilinogen spontaneously degrades into urobilin, and that's what gives it the yellow color.
Ta-da!
So if you're ever asked that question on Jeopardy, what is urobilin is the answer to it gives urine its yellow color.
Oh man. So we figured it out on PharmaDocs. You gotta love it. All right.
And I just knocked a whole bunch of papers off my desk. Excuse me. You can talk.
So we'll take a little brief break right now while Dr. Resnick gets his papers in order. And so the first drug of December, Jay, right there, Fabhalta. What a Fabhalta.
Fabulous, isn't it?
Yeah, it's fabulous.
Yeah.
Okay.
Yeah. So this is a first-in-class complement factor B inhibitor indicated for the treatment of paroxysmal nocturnal hemoglobinuria.
Yep.
And what exactly is that, John?
Oh gosh, it's right there in front of us when the normal red blood cells actually it gets basically that, as you look on the far right there, the complement 5 goes to complement 5B, and then it basically attacks the membrane right there. And that's how we wind up with a PNH RBC.
Yeah. So what happens is the CD55 and CD59 molecules are prevented from with the PNH cells are prevented from attaching, and so it causes basically the cells to shrivel. And of course, these clog the blood vessels, leading to things like muscle pain, weakness. It can cause other symptoms like fatigue, dysphagia, dyspnea, abdominal pain, ED, hemoglobinuria, anemia.
I mean, look at
renal
everything
failure,
right there.
pulmonary
Yes.
So this
pulmonary hypertension. So, I mean, your patients can come in very sick due to PNH.
And maybe not even be diagnosed.
Correct.
And you could be the one making the diagnosis. The way, I thought I had one on the mechanism of this. So basically the way that the current treatments are complement C5 inhibitors that prevent the intravascular hemolysis. But what this drug does is it, let's see, where it's a targeted factor B inhibitor of the alternate complement pathway that acts upstream of the C5 terminal pathway to prevent both intravascular and extravascular hemolysis in PNH. And it's been shown to increase the hemoglobin level anywhere from 2 to 12 grams per deciliter, depending on what other adjuvant treatment the patient is on.
And now that's also, Jay, based upon those patients that are taking anti-C5 treatment as well, too, because that's been the previous treatment. But like you said,
this enhances the effect.
This is a first-in-class drug. So I mean, this is a great thing about doing PharmaDocs, Jay. I mean, we get to see all these first new drugs coming out that are making a difference in somebody or some family's life, man. I mean, it's great stuff.
It's a twice a day pill.
Yes.
So very easy for the patients to be compliant. All right, our next drug. This is a kind of a Swiss Army knife drug in a sense.
Great
Avzivi,
description. Yes.
It is a biosimilar to Avastin, a drug that we've talked about before. And this is used for the treatment of colorectal cancer, non-small cell lung cancer, glioblastoma multiforme, renal cell carcinoma, cervical cancer, ovarian cancer, fallopian tube cancer, and peritoneal cancer too.
Right.
On the peritoneum. It's a vascular endothelial growth factor inhibiting biosimilar to Avastin. and it's used to treat many, many different cancers. And so the way that it works is, John, why don't you take that?
Well, let me slide myself so I can see that right there. So when you'll look at the signaling model that we have on the left side right there, okay? And basically the multi-kinase inhibitors go in there and they'll block that. So therefore, angiogenesis doesn't occur with the tumor.
Right. And angiogenesis, the new blood vessels, is what promotes tumor growth.
That's right. That's feeding the tumor. So these new multi-kinase inhibitors block this angiogenesis. Therefore, if you can't feed the tumor can't grow.
Exactly. And this drug is used in combination with the traditional chemotherapeutic regimen for the various different cancers like colorectal and lung cancer, renal cell cancer, fallopian tube, ovarian, etc.
Yes.
And so this is a very new and very promising drug to help these patients with a variety of different tumors.
Yeah, like you said, it's a Swiss Army knife or the MacGyver type.
Yeah.
And what a that show always we always go back to that, don't we? The MacGyver or something, you know. What a great show! All right.
Yeah.
I hope our younger audience knows what we're talking
they're
about.
They're like, who? Yeah. All right. We should start calling each other on a rotary phone and see if we freak people.
Okay, look now. We've got this drug and another drug, Jay, for sickle cell disease.
Two unique drugs for sickle cell disease.
Both
that
came out in the same month.
The same thing, but by slightly different mechanisms. So the first one is Lyfgenia.
Lyfgenia, what a name! Lyfgenia, I love it. Made by Bluebird Bio.
Yeah, and this is an autologous hematopoietic stem cell based gene therapy.
Yes.
So they're actually altering the genes that form the abnormal hemoglobin. And as you know, with sickle cell disease, the blood cells in the right environment, the red blood cells, will develop this sickle shape and cause vascular occlusion all over the body and result in all kinds of problems: anemia, fatigue, painful joints, severe bone pain. It's really debilitating for these patients that have sickle cell disease. And it can be brought on by infections, trauma, going to the dentist. Yeah.
Yes. And I mean, that's something
kind of stress.
Yes, because, as oral surgeons, when we treat these patients, one of the key things or two of the key things, keeping the patient well hydrated, keeping the patient well oxygenated as well, too.
Yeah.
That can help reduce. And a third one, Jay, would be limiting how much you do on these patients as well, too.
Yeah. Yeah.
Because what you don't want to do is throw them into an event.
Right.
They take them from sickle cell disease into a sickle cell crisis, because honestly, you probably caused that then.
Yeah. So not preparing your patient properly.
Yeah. You need to be very careful and limit how much you're treating these patients, because the last thing you want to do is call to check on them. Oh, they went to the emergency department. They just had a sickle cell crisis.
Yeah. So you want to know a lot about sickle cell disease.
Yes.
If you have any sickle cell patients in your practice. So the way that this works, this is a one-time gene therapy, one time.
Yeah.
And what it does is it adds functional copies of a modified form of the beta globin gene, specifically beta A T87Q. And it goes basically into the patient's own hematopoietic stem cells via a stem cell transplant. So first, they use bisulfan to wipe out the bone marrow, and then they reintroduce these genetically modified, this particular beta globin gene back into the patient's bone marrow, and it basically treats them for life.
Yeah.
Yeah, wow. They only need this treatment one time, which is really pretty amazing.
Were you able to find a price of this? How much this costs?
No.
I couldn't either. I can only imagine.
Yeah.
But hey, guess what? I mean, there's not enough money out there to get, if you could find treatment for something like this, because
I mean, this is life changing.
It is
with a single treatment. I mean, just incredible. So the next drug is Casgevy, which basically does the same kind of thing, but it's using CRISPR technology. So they're basically, again, editing the gene with CRISPR and then reinfusing it back into the patient's bone marrow after they've ablated the patient's bone marrow, given a bone marrow transplant. And so, again, with sickle cell disease, we see occlusion of especially the smaller vessels that can lead to all kinds of severe pain, muscular pain, bone pain, severe tissue damage, etc. And so what they're doing here, this is the mutant gene, beta globin gene, and it goes through CRISPR editing, whereas with the previous drug, Lyfgenia, that was... Whoops, did I? Oh, no. Lyfgenia, they're actually injecting a modified gene, beta globin gene into the bone marrow, where they're taking the gene and modifying it so that it works properly. And so they collect the hematopoietic stem cells and progenitor cells from the patient's peripheral blood, and then it's edited with CRISPR Cas9 technology, and then a bone marrow transplant is done back into the patient's bone marrow, and this can give the patients, according to the study of 44 patients, 29 had complete freedom from severe pain and organ damage that can occur from sickle cell exacerbation. So this is the first medicine available in the United States to treat a genetic disease using CRISPR gene editing. Also,
but Jay, I mean, okay, in sickle cell disease alone, 16 out of 17 patients achieve primary endpoint of freedom from vaso-occlusive crises.
Yeah,
okay,
this is also
for at least 12 months. Okay, because I mean, if you got sickle cell disease, Jay, you don't know when you're going to go into crisis. Right. Okay, that's the thing about it. It doesn't make an appointment. You don't know. And then 17 out of 17 patients were free from hospitalizations due to VOCs or vaso-occlusive crises. Yeah. Man, this is just staggering.
Yeah,
here.
And this also is a one-time treatment that permanently changes the DNA in the patient's blood.
Man, we're just getting started with this stuff here. Yeah. I'm just telling you, okay?
All right. It's pretty fascinating.
Especially with the introduction of AI. There's just no telling what all we're going to be able to achieve here very soon.
Yeah.
Wow. So, hey, kudos to both these companies and what they have accomplished, man.
One-time treatment to basically eliminate the disease from the
because Jay, I know you've seen it just like I have. Those patients come in our office. Their biggest concern is going into crises. Yeah. All right.
Yeah.
I mean, they're just dreading it. Yeah. All right.
Yeah. Because it's happened before, and they don't want it to happen again.
They don't want to go back and have that severe bone pain and having to get on morphine or Dilaudid in the ER because they have to be on heavy narcotics for this.
Yeah.
All right.
It is extremely painful.
And Jay, that's the other thing. We haven't even mentioned that. Stopping these VOCs, that means less opioids for these patients, less likelihood of some form of future addiction down the road.
Yeah, for sure. That's a side effect of the benefits of this treatment.
That's right.
All right. So let's see. Our next drug is Iwilfin. I will. It's an ornithine decarboxylase inhibitor used to reduce the risk of relapse in adult and pediatric patients with high-risk neuroblastoma. So what is neuroblastoma? It is basically it's the most frequently occurring extracranial childhood tumor that is seen. The two most common, it's third most common in general after leukemia and brain cancers.
Highly aggressive.
It's an embryonal neuroendocrine tumor originating from the neurocrest progenitor cells and it can occur anywhere along the sympathetic nervous system, including superior cervical, paraspinal, celiac ganglia, but the majority arise in the adrenal glands. And so it's got variability in its presentation. But a lot of times what happens is the patient has a visible mass. And so patients may have actually this kind of black eye, periorbital ecchymosis. Yep. They may have masses that are seen on the chest wall, on the abdominal wall, in multiple areas. And so you can see on CT scan, on this abdominal CT scan, this is a huge tumor.
Yeah.
Yeah. So some of the other symptoms, in addition to just the masses or lumps, are patients may have pain, they may lose weight, they may be fatigued, have problems breathing, and also have easy bruising or bleeding.
And Jay, when you looked at some of the studies, at 4 years following immunotherapy, EFS in the Iwilfin treated patient group was 84%.
Yeah.
Then 96% of the patients, Jay, treated with Iwilfin were alive, compared to 84% of the external control patients.
Yeah. Just by inhibiting the enzyme.
It's given twice a day.
Decarboxylase.
It's a tablet. All right.
Yeah. It inhibits, it basically suppresses tumor growth and formation. And it's, very effective. Just a simple tablet.
It's just awesome. I mean, as a parent with children like you are, those parents that are going through this right now with their children, here is a great product.
Yeah. This is a drug that will change their child's life. Okay.
What about
next,
Avglo?
Avglo. For primary immunodeficiency syndrome, it's an immunoglobulin intravenous infusion, basically. 10% immune globulin for treating patients that have primary humoral immunodeficiency.
PI.
For adults. And the way that this is usually diagnosed is if you have a patient that has recurrent infections like serious sinus disease or pneumonia twice in 1 year, persistent fever, if they've had sepsis or meningitis twice in a lifetime.
Yeah.
That also is suspicious for a primary immunodeficiency, or if they have infections from opportunistic infections like Candida albicans and pneumocystis also in addition, and non-tuberculosis mycobacteria. So those are kind of the clues, because these patients are difficult to treat.
Very.
They require IV antibiotics and hospitalization. But complications from primary immunodeficiency include abscesses in organs, non-healing wounds, chronic diarrhea, in children, failure to thrive, all kinds of lab abnormalities like leukocytosis and an elevated eosinophil sedimentation rate and C-reactive protein. And on imaging, they show bronchiectasis. So a lot of manifestations of this primary immunodeficiency, of which there are multiple flavors.
Oh, I know.
Depending on which stem cell or which branch of the stem cell is affected. And here you see DeGeorge syndrome, Behr lymphocyte syndrome, Wiskott-Aldrich syndrome, chronic granulomatous disease, congenital granulocytosis. There are many. So basically, John, why don't you talk about the different syndromes that you may see?
Yeah, I mean, that just feeds off what you just said on the previous slide. When you look at the various syndromes, DeGeorge syndrome, Wiskott-Aldrich syndrome, ataxia-telangiectasia, Ivemark syndrome, and then polyendocrinopathy syndrome as well too. And so you'll see the various different clinical presentations in the middle column right there for each one of those syndromes.
Yeah.
And then each of them have a unique immunological abnormality to them as well.
Right.
And it's amazing that this drug, Avglo, can help all of these.
Yeah. Yeah.
It's far reaching in its ability right there. And so, I mean, before, Jay, there really, each physician had to treat each of these disease states separately.
Yeah. It's
now they're all lumped together.
So it's an immunoglobulin replacement therapy that boosts the immune system to reduce the number of infections and other problems. So it contains a broad spectrum of neutralizing IgG antibodies to both bacterial and viral pathogens and their toxins.
Yep.
All right. Next, we have Filsuvez.
Yes.
Filsuvez, yeah, which is for treating a very uncommon but very serious disorder known as epidermolysis bullosa. And this, when I went through medical school in dermatology, this was the only true dermatologic emergency when this occurs. And so it occurs both in pediatric patients and in adults. And basically what's happening is just massive blister formation all over the body.
Yes.
Just from touching or rubbing on the skin. And there's essentially no cure. They can manage some of the symptoms, but there really is no cure. And it affects about 500,000 people in worldwide. So 1 in 30,000 people are infected, and it occurs males and females equally. There are 4 different types. EB simplex, dystrophic EB, junctional EB, and Kindler syndrome, and 30 different clinical subtypes. And it's all due to a genetic mutation. And so you can see how the skin, basically, the epidermis separates from the dermis and can lead to a lot of disfigurement.
Look at that. I know.
Yeah. It's a really serious.
But Filsuvez is not a cure by any means, but it's the first approved treatment for wounds associated with JEB.
Yeah.
All right.
It's a topical medication.
Yes.
So it's this birch triterpenes that are placed directly onto the EB blisters and lesions. That helps with resolution. Anything else you want to say about?
That's it.
Okay.
Yeah.
All right. So our last drug is
Wainua,
which is treatment for hereditary transthyretin mediated amyloid polyneuropathy. And so this is a directed oligonucleotide indicated for the treatment of this disease. And so the way that it functions is these TTR tetramers, the transthyretin mediated amyloid tetramers basically dissociate and they fold. And when they fold, they form these collections of amyloid that can be all over the body. And they can be, throughout, they can cause nerve damage. They can be basically throughout the system. And what this drug does, as you can see here, it affects basically every system in the body. It's a antisense oligonucleotide. So basically what it does is it binds to the messenger RNA and prevents that mRNA from being translated into a protein.
Jay, the thing about it, talking about with the amyloid, you have to think one day, will this somehow, because when you have amyloid buildup in the substantia nigra in the brain itself, that's the genesis of Alzheimer's.
Yeah. Yeah.
And how do we reduce that beta amyloid? You
Yeah.
have to wonder, could this drug ever be used for that as well too?
Yeah.
Because
I mean,
it's affecting the amyloid.
Yeah, this is a different type of amyloid, but also affects the nervous system peripherally and centrally, and leads to all kinds of problems, including loss of motor function, etc. So this is, and it's also being studied in the treatment of cardiomyopathy associated with this type of amyloid. So that's interesting. So those are our drugs for this month, and so. Now let's move on to our medical emergency of the month. It can happen at any time of the day in the dental office.
Or anywhere.
Anywhere.
And the three critical things, Jay, are sudden loss of consciousness, no breathing, no pulse. So out there, PharmaDocs Nation, what is this medical emergency?
And this is one that is so important to know that we're
sudden cardiac arrest.
Repeating it again because we did this last month. Sudden cardiac arrest.
Well, no, actually, we just did myocardial infarction.
Oh, I looked at the slides. It said sudden cardiac arrest. Okay.
We did this a year ago because of the significance of the Damar Hamlin.
Yeah.
It was a year ago in Cincinnati, since we brought up Cincinnati. Damar Hamlin had the on-field incident, sudden cardiac arrest. And that's right, Bronny James. That's right.
Yeah.
So two major sports players had sudden cardiac arrest.
Yeah.
And thanks to the preparation, pre-game preparation, these people are alive.
Yeah.
All right.
And swift action.
The only treatment for sudden cardiac arrest, and Jay, and we've talked about this ad nauseum, we talked about it in all of our courses, is a defibrillator. You've got to have a defibrillator. And I just, I talk to a lot of people that are BLS instructors, and they go into dental offices. They don't even know where their AED is. Yeah. Wow. The batteries have been expired for 2 or 3 years. The pads have been expired. People, I'm telling you, if you have a sudden cardiac arrest and a patient dies in your office and you have a non-functioning defibrillator, you will not have a defense, period.
Absolutely.
All right?
Yeah.
Now, I mean, Jay and I have done a podcast. We have a course on what happens when a patient dies in your office. And we go over about at least 60 questions. The plaintiff attorney is going to ask you about your status of medical emergency preparedness. And you're not going to be able to defend yourself because you didn't take care of preparing yourself.
Yeah.
And Jay, 1,000 people die every day in America.
Yeah. Actually, John, I don't know if you saw this. I think it was in Doctor Bicuspid, and it didn't give a lot of details of a dentist who had a sudden cardiac arrest in his office and died.
Oh, gosh.
Because his office staff was not trained.
Jay, I missed that. I've got to go find that.
I think yesterday. Didn't give any details.
Okay, I missed it. Okay. So, and that's the other thing too,
Somewhere
Jay.
in the Midwest. Yeah.
We talk about this all the time. Have that defibrillator, but have your staff trained in the event you're the medical emergency.
Yeah.
Because people, you've got about 3, maybe 4 minutes to shock somebody, and hopefully you're doing high quality CPR. But Jay and I taught a course not too long ago, and we deliberately had a skills station with it. And Jay, you know as well as I do, not a single person did high quality CPR correctly. All right.
Yeah, because let's face it, we've all taken BLS renewal courses. Yeah. And even ACLS, and they have really gone downhill since I started doing ACLS, 30 years ago. They just don't. They basically kind of push everybody through. I mean, everybody automatically passes, whether they know what they're doing or not, which is really sad.
Well, think about, Jay, when we did our skills station course. And I loved all the dentists that attended. Even in our anaphylactic course, the dentist understood, we call that a 3 minutes to life or death emergency. the dentist could not do everything by themselves. They couldn't
Right.
draw up the drug. Who's going to maintain the airway?
Yeah. No, it's a true team effort. You got to make
Yeah.
sure that
Because your staff can't draw up the drugs for
Yeah.
you, Jay. You have to do that.
Yep. Yep. This is it's very important because it could be you that's having a medical emergency in your dental office. So remember that sudden cardiac arrest is not the same as a heart attack.
Correct.
So we kind of split them into electrical versus plumbing.
Correct.
Okay. So sudden cardiac death is an electrical dysfunction where the patient is instantly unresponsive, not bleeding, not breathing, the heart stops.
Yeah.
Whereas with a heart attack, it's a plumbing issue. The patient's heart is becoming ischemic, but they're still responsive and breathing and their heart's beating.
They don't need CPR.
Unless it degrades into sudden cardiac arrest.
Or into cardiac arrest.
Yeah. So electrical problem versus a plumbing problem.
Yes.
And there are cardiologists that are electricians and cardiologists who specialize in the plumbing. It's interesting. So you have the electrophysiologists, and then you also have the cardiologists that really are more concerned with the plumbing issues. And sometimes patients will see both depending on their problem. The symptoms of
they're different, male versus female.
Of a heart attack, again, because the heart muscle is ischemic, the patient will have sweating, shortness of breath, pain in the chest, this classic indigestion. What's interesting is that heart attack symptoms are different, or some of the symptoms are different between men and women. In men, one of the big symptoms is this sweating.
Yes.
Whereas in women, dizziness is a more prominent symptom.
And back pain between the shoulders, the shoulder region.
Yeah.
Okay.
In women, whereas in men, it'll be more down the arm or in the chest or the jaw.
Yes.
Yeah. All right. So I guess that ends our medical emergency of the month.
Jay, I just hope everybody takes it serious about getting your office ready because, we're going to get it in one of our courses and one of your courses coming up. But I mean, there's so many medical emergencies out there. And like we always give you the clinical symptoms right there. And you got to think about, okay, what could this be? With 24 different medical emergencies, there's all kinds of signs and symptoms.
Yeah.
All right.
Yeah.
And you don't have much time to react through there, but please remember, call 911, please.
Yeah. Yeah. First thing you should do if you're, unless it's, a minor syncopal or pre-syncopal episode that you know how to manage, otherwise call 911. So
great course right here.
We have a number of courses that are available online at dentallearning.net. Both John and I have courses, some together, some separately. If you have still to complete all 8 hours of your MATE requirement, or you have not required your state mandated opioid education requirement, I have a course that will satisfy both of those. Some states like California, we have a specific course. They have their own course, which I have available. But for most states, they will accept this 3-hour course. So that's available on Dental Learning. John, you have a course on anaphylaxis update for 2020.
Yeah, absolutely. Did that. I'm about to update it for this year as well too. And about almost 2.25 hours long. And it just goes into everything about anaphylaxis. And this is one of those medical emergencies that's a life-threatening medical emergency. You got about 3 minutes.
Yeah.
All right.
You got to be able to recognize it immediately and know immediately what to do.
And as you and I just talked about our anaphylactic skill station, not a single dentist got it done in less than 3 minutes. Yeah. Okay. All right. And they were practicing with us. Most of you listening right now have never ran an anaphylaxis drill in your office. Yeah. All right. I would highly advise it.
Yeah.
All right.
Definitely.
Next.
All the different emergencies. And then John mentioned this one earlier. Patient dies in your office. Medical emergency goes bad. What happens next? This is something that will hopefully never happen to you, but this is, I think it's an hour. 2-hour course.
2 hours. Yeah.
Where we talk about, should the unthinkable happen in your office, how do you prepare yourself? How do you prepare your office for the unthinkable? And then finally, our IV sedation course, again, at VesperInstitute.com in Cincinnati, Ohio. It's a beautiful facility.
Yes, first class.
We have state-of-the-art facilities, and one of the components of our course, in addition to the online and live in-person learning, is the skills station, which takes basically a whole day.
It's all simulations
with very high quality, very realistic models and mannequins. So it's one that if you're thinking of IV sedation, and there's all kinds of reasons why you might think about IV sedation in your office. You may have, patients that have longer procedures and you'd like to make them more comfortable. You may want to make your practice attract patients who are too anxious to go to the dentist that need sedation. Yep. Multiple reasons why IV sedation will enhance your practice and raise it to the next level. All right. Thanks for joining us. Our next episode will be on February 9th with all the drugs that come out this month in January. And we will have a new medical emergency to go over with all of you. Yep. And with that, get rid of the slides. We will bid you
farewell.
Adieu.